My name is Tanios Bekaii-Saab. I'm a professor of oncology at the Mayo Clinic and a consultant at the Mayo Clinic on our Arizona campus. It gives me a great pleasure to talk about advances and updates in the management of colorectal cancer. Quite a few things are changing for the positive, as we're seeing a lot of improvements in the way we treat patients, and the way we diagnose earlier, and improving the survival of this cancer significantly. These are my disclosures. So first, I want to start with one of the things that's becoming obvious in our practice is, although colorectal cancer overall the diagnosis of colorectal cancer is coming down, one group of patients where this is actually growing in incidence is what we call the young adults with cancer, those younger than 50 or younger than the age of 55, depending on what definition you use. The median age remains around 67, but we're seeing a surge of these younger patients. And when we look at the trends in terms of the primary location by age, it's very obvious that most of it is coming from the rectum and the distal colon, at least, the major contributor for the younger patients. Now, these we are mostly sporadic. Most of the surge in younger adults is not really related to familial history. In fact, most of those patients have no history of family with colon cancer or other cancers. Now, we do know that about 20% of patients who presents with colon cancer, although we cannot pinpoint a specific syndrome, have a family history. So likely some genetic link yet to be discovered. Now, we have done a study. We published those results recently, at least those focused on colorectal cancer. The gist of the study is that we took all patients with cancer, and in this subgroup, 300 plus patients with colon cancer, colorectal cancer, and we did universal germline screening. So we didn't go by guidelines. We said everyone that goes through the door, we're going to screen them for a genetic cause for cancer. And what we found actually is about 15% of the patients will have an identifiable risk. The most common was actually a check mutation. The second most common was MSI or Lynch syndrome. So this was interesting, because if we went by the guideline, by the guidelines, we would have missed at least 25% of patients with colon cancer that may be linked to a genetic syndrome. Now, this has two things. This has implications on the treatment, especially in the more advanced setting. And we found that indeed that did affect treatment and treatment options. But also, of course, most importantly is a preventive measure, early screening measure for patients, families, first-degree relatives, and others. And in this study, we actually offered the opportunity for patients to have their family members tested. So now we do universal genetic testing, germline testing on all patients with colon cancer. In fact, frankly, in all our gastrointestinal cancers, we do the same. And as you know, one of the main syndromes that have been described clearly in the literature linking to colon cancer, but also other cancers, is Lynch. And this is where we have deficiencies in MMR protein, or what we call microsatellite instability high. Now, about half of the patients, if not more, actually have what we call a sporadic mutation, meaning they're not necessarily linked to the Lynch syndrome. And by undergoing a RAF mutation, we may be able to figure out whether that's more likely to be Lynch or not. I say this is an older paradigm, and today, since we're doing universal testing, we still, check for those so nothing gets missed. MSI high is important to have for mostly for clinical treatment implications. But I do think that Lynch syndrome is now mostly diagnosed through the inherited genetic panels that we do on a routine basis in our clinics. As with all cancers, colorectal cancer staging comes in 4 stages: stage 1, 2, 3, and 4, and really depends on the depth of the tumor, and also lymph node involvements and the presence of metastatic disease. And that certainly alters somewhat the way we decide on treatment. Now, the stage 1 is mostly the polyp stage with cancer there. Treatment is surgical, 95% chances of cure, no further therapy. For stage 2, the low risk, there is very little benefit from chemotherapy, at least the way we select patients today. We'll talk a little bit about some elements that are coming that may help us decipher better who may or may not be eligible for chemotherapy. And then for those patients who undergo surgery, adjuvant chemotherapy, meaning therapy following surgical resection, has become a standard for high-risk stage 2, which means those with deeper tumors or with perforated tumors or obstruction, and stage 3 colon cancers, meaning lymph node positive but non-metastatic. And for those patients, we know that drugs like 5-FU and capecitabine, so the fluoropyrimidines, add about 15% to the cure rate from surgery alone. And oxaliplatin adds a little bit on top of this, about 3 to 4%. So most of the benefit comes from the fluoropyrimidine. Most of the toxicities come from the oxaliplatin, especially those that linger for the lifetime of the patient. So we want to figure out a way to actually shorten the duration of oxaliplatin, given the fact that it causes most of the toxicities that go with the patients for their lifetime. So this IDEA trial was developed to ask that question. This was a multinational study that looked at 12,000 plus patients, randomized patients to 3 versus 6-month FOLFOX and CAPOX, and essentially the two things that become obvious as expected. Cutting down on the risk, and the orange is bad, is the worst neuropathy. I mean, when we talk about grade 3 and 4 neuropathy, we're talking about patients who may not even be able to walk without assistance. So it's pretty dramatic. And when we're looking for patients surviving years and years, 10, 20 plus years, depending on their age, you certainly want to limit how much toxicity they carry with their cure. While, of course, preserving the chances of a cure. And it becomes obvious that cutting down to 3 months certainly improves significantly the toxicity profile, while not harming much patients. In fact, if anything, there's maybe a loss of benefit for 1 out of 100 patients on the disease-free survival, meaning how long it takes for the cancer to progress. But when we look at the overall survival, there's probably no loss, especially when you look at CAPOX. And CAPOX actually performs at 3 months as good as 6 months. FOLFOX, which is the infusion of 5-FU, seems to perform less well. So in my practice, I use CAPOX for 3 months. For the low risk, no questions asked. I mean, that's the standard, and not even a minute beyond the 3 months for treatment. For those patients with high risk, meaning more involved tumor or more lymph nodes, for those patients, I still favor 3 months of CAPOX. However, if decision between the doc and the patients is to proceed with 3 more months, I usually go just with the capecitabine alone, so the fluoropyrimidine without oxaliplatin, since most of the benefits comes from that agent. I don't give much FOLFOX in practice, but if you do, for the high-risk patients, you're probably obligated to consider 6 months, although again, with a trigger finger to drop the oxaliplatin and continue with the 5-FU once some neuropathy is going on. So for stage 2 colon cancer, at least the low risk, meaning those with, as we know, stage 2 is no lymph nodes, but those with less penetrating tumors, so less than T4, you have to treat 100 patients to perhaps benefit 4. And I don't even think that we benefit 4, probably 2. So we know 80% of the patients are cured by surgery alone and really do not need chemotherapy. and another 20%, or say 16 to 18%, will recur regardless of surgery and chemotherapy. So only 2 to 4% of those patients will need chemotherapy. So is it a good idea to expose every patient to chemotherapy only to benefit 2? Well, of course, for those 2 patients, it makes a lot of sense, only if we can find them. But unfortunately, we expose so many to unnecessary chemotherapy. So how do we do this? Well, we're learning ways to try to improve our likelihood to predict for who may benefit. So when cancer breaks down, it releases DNA, genetic material. So these circulate in the blood. We call them circulating tumor DNA, and we actually capture them, and we can assess them in that sense to help us understand, whether there are any cancer cells or fragments of these cancer cells, circulating tumor DNA, roaming around the bloodstream. And there are 2 platforms that are available to us right now. The one that I prefer is the tumor-informed, and I'll tell you what that means, and the other one is tumor-naive, which is much more practical, but you lose some level of accuracy with the tumor-naive. With the tumor-informed, you need to take the tumor tissue from the surgery and personalize the assay and then match the blood to it. This does take a little bit longer, but also it does improve the accuracy because you're able to match the blood to the tissue. The tumor naive is you essentially don't need the biopsy, it's off the shelf, but it actually looks at, as what we predict is most likely to be linked to colon cancer, say. The problem is we do lose some level of accuracy when we do this. So my preferred, and most of the studies so far, except a couple, have focused on tumor-informed. Now, and I'm going to cut back to that a little bit. The whole concept of actually looking at these fragments, DNA, circulating tumor DNA in the bloodstream, is actually revolutionary in the sense that it helps us not only now understanding, whether there is a residual disease from the cancer after surgery, but it also helps us in the more advanced stages to do molecular profiling, meaning check the DNA of the tumors from the blood rather than from the tissue, or in addition to the tissue. We'll talk about this a little bit more later. But also, one area that I'm very excited about is early cancer detection. So we're starting to take those circulating tumor DNA assays and take them to the earlier stages, see if we can actually screen for cancer sooner. But here I'm going to focus, since we're talking about the early stages, on minimal residual disease and what it means. So let's say, a patient undergoes surgery, and then we clear, most of the cancer, but yet there are a couple of clones, the yellow and the blue clone, that persist. And then we give adjuvant therapy, as is our standard chemotherapy, which appears to clear the yellow clones, but unfortunately, in this one particular case, it didn't clear the blue clones or subclones. So when we actually do regular testing, such as CA and CT scans, we don't typically find any disease. But then when we check the circulating tumor DNA, it lights up positive, which means essentially that there's probably cancer left behind. Now, unfortunately, the limitations, and I tell you here, the limitations of this is, at this point, we don't clearly understand what do we do with the positive results. If you've already gone through surgery and adjuvant treatment, do you treat unless you see a lesion somewhere? And the answer is probably not until we have more data. So more studies need to occur. Be very careful about getting this routinely in clinic. I discourage it, actually, except for very few select patients. It requires a long discussion because it can provoke a lot of unnecessary anxiety. And also, I'll also tell you that a negative result is not necessarily a result that should be comforting, because there's 20% of the cases who are negative that actually are truly positive. So until we enhance the accuracy of this exam, we still need some work to do. Now, in practice, we check scans, but we also check CAs, and many times, what happens is that CAs CT scans are completely normal, And then the CA, especially under 10, comes back a little bit elevated. So we have those patients with the CAs of 6 or 7. And there's a lot of anxiety for me, for the patient around it, because, we're wondering whether this indicates that the cancer is coming back or not. We check scans again, PET scans, all this stuff, and nothing comes back. Plus, it turns out that about half of the patients will have elevated CA within the 5 to 10 range that are false positives, meaning that they're not a true reflection of the cancer progressing. So this is one area where actually I may do an MRD test to ensure that I add one level of certainty to the fact that the patient may indeed be in that false positive category. A number of studies today are looking at understanding how can we take that MRD test and put it in clinical practice. And one of those is Circulate study in Japan. There's also Circulate study in the US that's assessing again, the role of intervention in patients with MRD positive, or no intervention in patients with MRD negative. So, for example, some of the early, and these I would say these are observational findings, meaning these are not randomized or where there's a flip of a coin. These are just observations, meaning the physician decides how to act on the results. So these are good. They give us a preview of what may come from the randomized trials. It does not replace the randomized trials. And I say that because it's very important, again, given the fact that there is a lot of patients, so 20%, 2 out of every 10 patients, who may show a negative test that still have a positive cancer clone lingering around. And I don't want essentially to deprive my patients of the opportunity to receive chemotherapy if they still need it until we get further validation. But this gives us a first peek at this, saying, well, you may be able to, as long as you validate that in the near future, we may be able to essentially avoid chemotherapy for patients who may not need it. But that's fantastic. I mean, that's really where we want to get, given what we've talked about. A study called the Dynamic Study was presented at ASCO this year. And this one actually, this actually randomized patients to standard management versus ctDNA guided management. And essentially the patients who were positive went to adjuvant chemotherapy, or negative went to observation versus standard management. And essentially what we see is that the ctDNA guided management did not appear to cause any harm in terms of loss of benefit from the patients, which in other words, that using this ctDNA guided management may provide the opportunity for some patients to be treated that would otherwise not be treated, and vice versa. Now, I would caution, though, that this should come with a grain of salt, in the sense that we still need larger studies with a randomization to intervention in the positive group and negative group before we make complete sense out of this. But all these are continuing to trend in the direction that we're going to get to the point where patients will be treated according to multiple factors, including circulating tumor DNA. So I'm very excited about where this is going. And I think hopefully we'll get to the point where the use of circulating free DNA will help with de-escalation of adjuvant therapy or escalation, depending on the findings. We're not there yet. A couple of studies in the US, in addition to the one in Japan, this particular study here, Circulate USA, is addressing this question specifically about what to do in the presence of positive versus a negative finding. Some of the very interesting recent findings are actually in the mismatch repair deficient, so the MSI high, a group of early cancer. So we know that in the metastatic setting, we've already had some significant outcomes, and we'll talk about this a little bit in the MSI high subgroup. But now we're starting to see those translating into the early stage of the disease. With this one study that was recently presented and published in New England Journal of Medicine, looking at a small group of patients, 12 patients, with rectal cancer, so the lowest lying tumors. Rectal cancer surgeries can be pretty tough, and many patients can end up with a bag for their life. But also those patients who don't may end up with significant issues with diarrhea and quality of life matters that essentially prohibit them for the rest of your life to have normal functioning. But it is important to understand the role of these PD-1 inhibitors in those patients who we expect to have tremendous responses with rectal cancer and colorectal cancer. So the study essentially showed that for 12 patients, so it's a small number of patients, but for the first 12 patients that were treated with an agent called dostarlimab, that the rate of clinical response was 100%. 100%. Now, the follow-up is still not mature enough, meaning we haven't seen on the long term how this will fare out. But so far, 0% of these patients needed any further radiation or surgery. None of them progressed so far. So we'll keep our fingers crossed that this will continue to be the case as this matures beyond this study. And then we've heard from Europe, from ESMO this year, that another study called the NICHE-2 study essentially looked at dual checkpoint inhibitor in locally advanced colon cancer. Now, these patients did undergo surgery, so they had their checkpoint inhibitors, then they had their surgery, and then you see that 95%, this is the plot there, which means almost every single patient had a response, and then 95% of the patients actually had a response, and about 2/3 of the patients had what we call a pathologic complete response, meaning by the time they went to surgery, there was absolutely no evidence of remnant cancer in their tissue. And one would wonder whether those patients actually do need surgery, and the next study is going to look essentially like that, meaning that patients will receive just the treatment and hopefully will avoid surgery or any further treatment. So it's an exciting time. I mean, this is for about 10 to 15% of our patients with colorectal cancer in the early stages will have mismatch repair. And perhaps for that group of patients, we may be able to cure them without the need for any other local intervention. So when we think about our treatment choices in advanced colorectal cancer, a number of characteristics come to mind. Patients' characteristics, so of course, a lot of these elements come into the equation in the discussion. Tumor characteristics, the burden of disease, tumor location, right versus left is important. And then molecular characteristics, mutational status, and we're talking about the tumor mutational status in addition to the germline. And the right versus left look a little bit different. The left-sided have different level of mutations. They occur mostly in men. The right-sided essentially mostly in women, older age, but also have the highest rate of MSI high. And then as we talked, it's important to have the genetic biomarkers available on hand, both the germ, what we call the germline, as well as the tissue-specific findings. And there are tumor versus liquid biopsy findings that we use routinely in clinic. There are pluses and minuses. In my clinic, I use both. As soon as I see the patient, I send a liquid biopsy, so assess for these fragments of DNA, and then the tumor biopsy, which essentially assesses the tissue biomarkers. The liquid is fast, but it may lose some biomarkers. The tissue takes more time, but for the most essential biomarkers, I think we can already make a lot of sense of what the tumor looks like from the liquid. And so that does affect in some ways, our first line treatment for a microsatellite stable metastatic colorectal cancer, because it's important to know RAS, RAF type, the HER2 amplification level, in addition to the sidedness, because that may decide whether the patient would receive an anti-EGFR treatment or not. Age may also lead us down the path of a triplet, a more aggressive regimen, followed by maintenance therapy. All these should be actually led by maintenance therapy. And then more and more, we're becoming reliant on understanding these relevant targets in metastatic colorectal cancer and what they mean to our practice. There are many important that I'll go through. The most important, of course, is what changed a lot of what we do is MSI high tumor. So in this sense, Keynote 177 looked at a first-line pembrolizumab in MSI high colon cancer versus chemo, and you can see a huge improvement in outcome. I actually have, this is metastatic, so this is stage 4. About half of the patients, a little bit less than half the patient, were cured from their cancer just with pembrolizumab. This is in stage 4 through exposure for 2 years, and the survival appears to be better. BRAF V600E mutations, the drivers of very aggressive cancer, are present in about 5% of patients with colon cancer, and single agent applications don't appear to be useful. And so we have approvals for dual therapy with encorafenib, which is a RAF inhibitor, and cetuximab, now being looked at in the first line with chemotherapy to try to take on the advantages that we've seen in later lines. Another target of interest in colon cancer, which was mostly relevant in breast and gastric, is HER2. And what we found out is that in this 3 to 4% of patients with colon cancer will overexpress HER2. And these essentially patients, we know from preclinical models, may benefit from dual therapy. So not just one agent, but 2 agents. So we recently presented data on a study called Mountaineer with an oral tyrosine kinase inhibitor, so an oral agent added to the traditional antibody called trastuzumab in HER2 positive cancers. And what we found essentially that about 40% of the patients will have responses, including about 4% with complete responses. And these responses tend to be extremely durable. I have patients who are 3-4 years just on the dual therapy, doing great at this point of time, appears to be pretty safe. And now a first-line study called Mountaineer 3 is looking at the combination of the 2 drugs with FOLFOX versus FOLFOX plus standard biologics. Of note that tucatinib and trastuzumab now is making its way to the FDA. So if the FDA approves that, it will be the first HER2 target therapy in colon cancer. Very excited about it. The review will happen somewhere in January, so hopefully we'll hear some positive news, but we'll see. And then trastuzumab deruxtecan is another anti-HER2 strategy. This is more chemotherapy being linked to an antibody, delivers this directly to the cancer cell into the tumor and achieves a cancer kill. So we have a number of these regimens that are available. I think the one that appears to be the most promising is tucatinib trastuzumab, and then trastuzumab deruxtecan. And this actually allows us to sequence the 2, usually trastuzumab deruxtecan following the dual therapy. Another subgroup of patients is a KRAS G12C. KRAS mutations are omnipresent in colon cancer in about 40%, and G12C about 3 to 4%. This is the first KRAS mutations that is targetable by an agent. And you have to combine this agent with an EGFR inhibitor, adagrasib, or another agent called sotorasib, both being developed. We presented updated data at ESMO, which essentially did show, I mean, again, almost every single patient had a response, some level of response, except a couple on the study, with a response rate being about 50%. But every patient had what we call disease control rate. And you can see here that all these patients have had responses ended up having some durable responses, some of them actually still ongoing 2 years later. Pretty amazing for this group of patients. And this is now going to a phase 3 study. So as we're seeing, the more we're selecting patients for targets, the better we're doing overall. And this is really driving quite a bit, the successes we're seeing recently, whether it's BRAF, HER2, or others, and track fusions, MSI high, we're seeing these magnificent responses in our patients. So I think, one can easily conclude that every patient with a diagnosis of colorectal cancer should offer both germline testing and somatic tumor profiling, whether by tissue or by liquid. And finally, I will show you, how complex this treatment paradigm for colorectal cancer has become. So we look at side, we decide on BEV versus anti-EGFR for MSI high, it's IO. Then we decide on the right-sided tumors whether we want to be more aggressive. For those patients with BRAF mutations, we go with encorafenib and EGFR or on study now first line. For HER2-amplified tumors, we start with dual HER2 therapy, then follow that by an agent called trastuzumab deruxtecan. We also have some small groups with TMB high and NTRK fusions where we can apply some of these agents. We have more agents in the unselected patients, meaning those with no identifiable targets, such as fruquintinib, which was shown now to be positive and is going to the FDA, regorafenib, TAS-102, and then, of course, you know, that KRAS G12C subgroup of patients, which appears to be also doing extremely well with combinations such as adagrasib, cetuximab, sotorasib, panitumumab, and studies ongoing right now, and more RAS targeted therapies coming down the pike. So a very exciting time for colon cancer across all its stages. So I want to thank you for allowing me to present this.